So in early development, early childhood for these people, borderline with high volume, they learned that they weren't going to get love and attention if they didn't threaten mayhem normally. So they weren't given love in ways that was consistent. For example, when they needed to be held close and loved and made to feel safe, they were pushed away. And when they needed to have autonomy and independence and roam on their own, they were held very close. So there's this very confusing message that they received, which is, when I try to wander off, I'm just going to get swooped back in again and confined and engulfed. But that when I need to feel safe and I need to feel loved and I need to feel secure, I'm going to be pushed away. And this manifests in all of their relationships, the push-pull, push-pull, push-pull. Too close, too far. There's an inability to tolerate middle space. The final piece for the borderline, so we've talked about splitting as a defense. We've talked about the inability to master peekaboo. We've talked about the too close, too far, too close. This last one is called ego strength. So, imagine you're playing baseball. That's, playing catch. You throw the ball, catch it, take it, throw it back, partner catches it, catch it with your glove. For someone who's a borderline, when they play baseball and the ball gets thrown at them, there's no glove. And so the ball just, boom, hits them right in the head. What I mean by that is this. Any comment directed towards the self is taken as an attack or a critique. So what this looks like in our setting is this. So I really liked what you said in group yesterday. It seemed to really kind of open up the group, and it was very directive. I'm noticing you're really kind of growing, and it's very cool to see. And they say, so yesterday in group, I wasn't doing something right? And you go, no. I just wanted to say today you did really well. It was very nice to see this. No, but what you mean, though, is that yesterday I was doing something not right. So they can't take in the good. They can't take in that good, nice piece of affirmation. Instead, they see it as a critique on the self. Anyone have any examples of that? Yeah.
I have a question.
Yes.
Is it easy to confront the borderline and the narcissistic and say, you're borderline, you're narcissistic?
We'll get to that. We got a body armor. They'll ask. Yeah. Can we do some Q&A in about 10 minutes? One more? Sure. Oh, yes, example. I'm sorry. Go ahead. Yeah.
Get through this session with a client.
Yes.
Great, wonderful. You get a phone call from that parent's mother that night. How you're the worst in your life.
Boom. That's it. Yeah. So something happened after session. Something happened in the mind where that you've been either split or something you said just didn't quite settle right. Yeah. Definitely. So the borderline with poor ego strength is like this. They're like a burn victim with third-degree burns over 90% of their body. So think of it like that. So imagine touching someone with those kind of burns. It's excruciating. It's excruciating. They don't have the skin to tolerate these kind of comments. They're burn victims. It's very sad. So their relationship with drugs and alcohol, right? Where the narcissist used drugs and alcohol as a way to fulfill self-esteem, the borderline uses it for a different purpose, which is to feel secure, to self-soothe. So when feeling alone, you can drink, which they feel often. When they're bored, which they feel often, drink or use. When angry, which they feel very often, drink or use. When isolated, same thing. When engulfed, same thing. So instead of making them feel outstanding, which can happen a lot of time because there's a lot of overlap between the two, for the classic borderline, they're using it more as a self-soothing kind of security blanket. Okay. So here's where we get to treatment implications. To answer to your question, the key with interacting with someone who's organized at a high-level borderline is to strike when the iron is cold. So you never want to make an intervention when they're decompensating. It won't be received. It can't be received. Because any of your interventions, you're going to see the burn victim mentality come out again and an inability to kind of take it in. It'll hurt too much. So the way to treat them is to, when they're in a more regulated place, then make those interventions. Then say something like, yeah, I did notice that, sometimes you come in to session and you're feeling great about our relationship. Because psychodynamic theory, we're talking a lot about the relationship we have with the client in the room. So I feel like sometimes we're doing well together in our therapeutic relationship. Other times you come into my session and I feel like you hate me. What do you make of that? Saying something like that when they're a little more regulated, you might have a little more room to do work, rather than saying it when they're decompensating, they don't like you, they hate the treatment center, they want to leave. The key with the borderline is to have strong boundaries. Something they never received were clear boundaries, and something that over time they'll appreciate if they do stay and they don't AMA are clear boundaries. These are your high AMA risks, definitely. The key, where you're dealing with a borderline, and I laugh because I've sat in on so many clinical team meetings, and you don't even know, you need to know the client history to know you're dealing with someone with a high volume borderline level. Half the staff wants to rescue them and thinks they need to be helped, and the other staff is like, we got to get rid of this person. They need to go to a different level of care. It's a complete split amongst the staff. So they've been able to keep, they can be very charismatic, engage half the staff and make them feel the need. This person is so and they are very traumatized, so traumatized, we should use all of our resources to help them. We should employ all our clinical resources to help this person. Half the clinical team will feel like that. The other half will say, this person is a danger. This person has threatened to call the state and get my license barred. This person is not appropriate for our level of care. And so these epic battles will play out in the clinical meetings. And that's when you know really you're dealing with someone with high volume borderline traits. So the countertransference, meaning basically how you feel, how you feel about your client, countertransference. What they tend to do is they'll elicit those responses of rage. One of my professors previous professors who specializes specifically in borderlines, he says, if at some point you don't hate them, meaning they've tried to get you to hate them, he said, if at some point you don't hate them, you can't help them because you're not tapped into what they want from you. They're going to push your buttons as hard as they can and get you to feel rage, absolute rage. So if you can't access that feeling and be comfortable with it, you can't help them. That's a really hard, savvy way to practice. You have to be pretty good. The other response is going to be rescuing, right? So these are the clients who you're going to stretch your sessions out with. So instead of 50-minute session, you know what? Let's book up 2 hours. Let's really go deep. Let's really make sure that we get everything we need to cover. And you'll find yourself, right, giving them the prime spot in your day, extending sessions sometimes, going over and beyond with the families. Really, they have this endearing quality oftentimes to try to get you to do more than you normally would. Because they are so wounded, and you do want to take care of them. Us as clinicians, we have that. The reason why we're clinicians oftentimes is because we have that innate sense to want to caregive, to want to help, to want to heal, to want to be of service. Whatever the terminology we use is, that's kind of innate to who we are. And so they can take that, and if they want, manipulate that. And if we're not aware of our own tendencies to want to kind of do that, then it can be destructive. And the last response they can elicit is going crazy. After a session or a few sessions with someone who is going back and forth and you don't know where to stand and they're constantly threatening to hurt themselves or hurt others, and one day you want to refer them to an inpatient hospital setting, the next day they're ready for your outpatient program, you feel crazy. It can make you feel really uncertain and lack confidence in your clinical skills. So these are all key indicators that you're dealing with this type of client. And finally, the psychopath. So these guys and women are manipulative, charming, lack remorse, issues with authority, aggressive, deceitful, lack empathy. With the narcissist, let me see if I'd have it here. Yeah. The primary defense that they employ is something called omnipotent control. And so all that means is puppeteering. The world is their chessboard. Someone with high volume psychopathic tendencies, the world is their chessboard. And they have this fantasy, this thought, that everything that happens in the world is the source, is because of oneself. It's because of oneself. It's because they've created it. They're master chess players with people and things, companies. The world is my chessboard and I must win. People are my puppets. And we'll see why this developed. So omnipotent control, the other defense. A few images. Who's that on the left there? Ted Bundy. And then on the right? Right. So on the one side, you have your deranged serial killers. On the other side, you have your kind of white-collar, urbane, polished psychopathic criminals. They both use the same defense, believe it or not. Ted Bundy's looks a little different than Bernie Madoff's. So from impulsive, sadistic, and deranged to urbane, polished, and charming. Here's the interesting thing. Their temperament in studies as children, they can handle higher than average thresholds for pleasure and excitement. So whereas as most of us in here can go to a movie, like an action film, and get that same kind of rush in watching a film, they would need to do something like that on a BMX bike to get the same emotional response. So their threshold for excitement and exhilaration and pleasure is extraordinarily high compared to what we would just need to feel, maybe watching a scary movie. They need a huge jolt to feel what we would just normally feel doing something pretty low-key. And the reason, here's kind of if you remember one thing about why, the why with psychopathic organization is they live in a world of pain and humiliation. Their childhoods were usually full of torture, humiliation, ostracizing, criticism, truly awful upbringings. So they live, their internal world is all about pain and humiliation. But the only way they can express this pain and humiliation is to inflict it on other people. And so this is why you see a lot of deranged psychopaths torture animals, is because in torturing an animal, it actually alleviates their own suffering. They have no way to express these feelings. Like you and I can talk about it, we can do work around it. They don't have that capacity. And so the only way they can get relief, imagine living with constant shame, humiliation, and rage. You want to get rid of it. The only way that oftentimes they can expunge it is to inflict it on other people and things. So there's this incredible relief that oftentimes occurs when they hurt people. And they hurt you as their clinician. They really enjoy hurting people, especially the people who want to help them. They don't experience common human emotions like weakness and shame as common human emotions. They experience them as feeling attacked. So hurting others alleviates their own pain. Ordinary emotions, weakness and vulnerability, are very difficult to put into words. So you're dealing with someone with the thing with narcissistic and borderline clients is they're often very charismatic and they're often very great verbally. They'll tell you a story, right? They are absolute great storytellers and their vocabularies tend to be very complex. Psychopath, not so much. Unless he has more narcissistic features, they have a hard time putting emotion into words. Very difficult time. The emotions that they allow themselves to feel are mostly rage and exhilaration. Rage and exhilaration. So things like shame, jealousy, envy are all defended against. Remember, we're shutting the door. Those are the big ones they shut the door on. They shut the door on shame, jealousy, and envy by using control and power. There's a thirst for control and power with someone who has high volume psychopathic traits. The quintessential example would be, Scarface, Al Pacino's character. So their relationship with drugs and alcohol, whereas the narcissist is about self-esteem, the borderline is about security. Psychopath is about sustaining control and power. If they can control you, then you can help alleviate their own suffering when they attack you. That's the driving fantasy. The clients who come in, and oftentimes their primary diagnosis is not heroin dependence, it's not alcohol use, it's drug dealing. The clients who come in, if you notice that their one thing that they're addicted to is the high life and wheeling and dealing, slinging drugs, these are the ones who tend to be more psychopathic. Because in drug dealing, there's an incredible amount of power and control. Your phone is constantly blowing up all day long. People are wanting you, calling you, needing you. Giving up that addiction is oftentimes the hardest thing to treat when you're dealing with someone who's a psychopath. Here are some treatment implications. So again, like with the borderline, you want to keep firm boundaries. So McWilliams says antisocial, which would be psychopath, people with the volume turned up high, do not understand empathy. They understand using people. They understand using people. And they will feel a sadistic triumph over and not a grateful appreciation for a therapist who wavers from strict boundaries. So you might feel like, hey, I'm giving you a little bit of a freebie here. Maybe we, instead of our session, in the office, let's take a walk around the campus. In doing that, you think you're trying to create this level of trust. They don't experience it as trying to create trust. They experience it as you're weak and that they got you. If they can force you out of your boundary zone, they know they can control you. So the basic things about your sessions, like payment, like when the session starts and when the session begins, after hours communication, all of these things when you're dealing with this type of person have to be maintained, or else they won't respect you, they'll see you as weak. And number 2 is uncompromising honesty. So the way to actually, unlike a borderline or a narcissist who might be a little too fragile to hear things occasionally, with the psychopath, go right at them. Talking straight, letting them know what you just did was hurtful, that will not be tolerated. Keeping promises, making good on ultimatums. These need to be done when dealing with someone like this. One of the things we say is, don't throw cotton balls at your client. Go right at their deepest anxiety. Right at their deepest anxiety. If he says, I'm thinking of hurting myself, don't say, it sounds like you have suicidal ideation. No, say, why haven't you killed yourself? What would you use? Show them that you mean business. That's the way to gain their respect, and that's the way to actually help them. So the therapist has to be a consistent, non-punitive, non-exploitable object. Non-exploitable is key. So here we have it. Narcissism with self-esteem, borderline about security, and the psychopath about power and control. So they help preserve their defensive functions. In my opinion, all addiction is a massive house of defenses. And part of our role as clinicians is to kind of recognize those patterns that we talked about, all these patterns with the narcissist, they use idealization and devaluation, with the borderline using splitting and problems with object constancy, peekaboo. Recognizing these things in them, or else they're stuck in what's called baby logic. Right? Their whole life, they've been able to use these defenses to get where they're at. And the defenses are how a child should see the world. So the goal would be to help them develop more mature defenses. Something like repression would be considered a more mature defense. It's just kind of pushing aside an emotion for a little bit instead of just completely splitting it. That would be considered a more mature defense. And in doing those things, you're actually helping them treat their addiction at the same time. So this is James Hillman. He's the founder of archetypal psychology, and a lot of what we talked about today kind of has come from the work he's done. He says, the study of lives and the care of souls means, above all, a prolonged encounter with what destroys and is destroyed, with what is broken and hurts. And so that's what you guys do. For those of you who are clinicians, you are constantly in this area of being with another person suffering in that dark place. And that's why the work you do, it's so important to take care of yourself, number one, and develop that capacity to kind of be with someone in the hurt and in the pain and with what is broken and what destroys and is destroyed, and take it seriously. I think with psychodynamic theory, we're not trying to change your thoughts, and this is not a knock on CBT. We're not trying to correct your thought process. We want to go right at your emotional core and stay there, and really stay there and be in it and talk about how you feel about me in the room right now. It's a very direct approach that privileges the relationship between the client and the therapist and how you're feeling about each other in the moment. So it's risky, but I think in this treatment setting and at the center that I've developed, we've tried to employ it in a way that makes sense, given all the kind of ways we are limited with insurance coverage and with all these other things that we all deal with. It's hard to do psychodynamic therapy in such a short-term setting, and so we have to be creative with ways that it's done well and done ethically. And then just some references. How much time do we have? 20 minutes. Okay, good. So I saw some questions. We can do a little bit of Q&A. Yeah?
How do you advise the spouses of the borderline narcissists and the family and stuff? How do you do this?
I think it depends. So the question was, how do you advise the families and the spouses of borderlines, of any of them? Has anybody had experience with that situation, doing family work with these people? Because this will help answer the question. What are some of the things you come up against in that setting? That doesn't fall far from that's exactly right. It doesn't fall far from the tree, right? So what's a way, knowing that doesn't fall far from the tree, how can we be effective in doing work in short-term settings? I think that's the real question. Yeah. Patterns. That to me is the most important thing, is if you can recognize the patterns. And I hate the phone call session. If at all possible, bring them in, everybody together. Something weird happens on the phone, in my opinion. As a therapist, I don't think you can you can't see, you can't feel it. If at all possible, try to get everybody in person. If not, okay. And then strike when the iron's cold. You don't want to meet with a family and do these interventions when they're in complete upheaval. That would be my recommendation. Yeah. Other thoughts, questions? Yeah.
So you mentioned
Trump.
So I'm curious to know as to, do you think he falls into the psychopath category? And
I think you do.
With all the hatred that he has expressed towards women, is there the mommy issues that appear to be present?
Wow, that's a big question. I think I know what your thoughts are. I think we can all say with him, the narcissism is obviously there. And I'm sure there's some psychopathic volume as well with what he's done with his business and that kind of puppeteering. I think looking at Trump as a marketer, just the marketer Trump, what he's done is fairly impressive. He's been able to kind of capture and coerce the kind of ideologies of huge groups of people, and when they don't work, brush it aside, which is what a psychopath does, and when they do work, capitalize on it. So the features are there. I don't know about his upbringing. I would assume that given the way he demonstrates his behavior, there's been some issues in early childhood. I've seen interviews with his children, though, and it was interesting. They all seem like just businessmen, like not so much his children, but like his employees. That was kind of my take. So,
But isn't it gross how his wife looks like his daughter and there's this
yeah.
and then how he wants to have sex with his daughter? I mean, he's talked about that openly.
Yeah, probably not good stuff. Yeah. Sure, yeah. Thank you. Yeah.
It's just a comment on Trump. I don't think you could take anything he says seriously. Every action that he makes is transactional. It has a purpose and a goal. And even his outrageousness, it feeds the audience that he has, and that's their audience. You can see him another time, but when I've been following this man since the 80s,
Yeah.
he's everywhere. You know, there is no core, which is that sort of continuum. I don't believe there's borderline and narcissism. I think that's one continuum. And
Sure.
some people are stuck on one end, and some people are stuck on the other, and it goes back and forth.
Sure.
But at heart, there's no there. And he is actually a very smart, though ignorant man. And everything is transactional. It's about what will work in this setting for this purpose at this time. And it will change tomorrow, or sometimes this afternoon.
Sure. Okay. Thank you. Yeah.
Can we get back on topic?
Yeah, let's do it. Go ahead.
So, we have a lot of borderline
Yes.
in our facility, and I've noticed the ones that are most difficult for me are the ones that almost wear like a badge of honor, this identity piece. And that makes it really hard because then they can be the ones that go through many treatments or like chronic. They can be advised because to them there's value in that identity piece, but at the same time it's also sabotaging and efforts.
Yeah. Great question. How long do you normally have them for?
It can range from 30 days. We've seen them as long as a year, which is very rare.
Yeah. 60 days. So having them a year is great, right? I mean, you can definitely do that deep work. The question was the borderlines who use it as a badge, like they know that they have that, they carry that diagnosis and they know it. How do you deal with that? I think it comes down to, your savviness as a clinician one-on-one and sitting with them and when they're not decompensating, exploring just exactly what that means and how that ties into their self-worth and then the loneliness. The thing that they fear most is being alone. And so they need to know that this kind of behavior and presenting it in a way that can be digested is going to be the key. They need to know that that kind of behavior is only going to lead to them being more alone. Yes, ma'am.
I was going to ask if your slides are available.
Yes. Yes. We'll make it happen. Yeah.
I found the borderline website.
Yes.
I have them in the treatment plan, I tell them that we're going to sit down and I have them put it in handwriting because if we talk about it, they only hear half what they want to hear.
Sure.
So when we're deciding what we're going to do, they write it out so they can see it. And then next time they say, this isn't happening, I say, pull it out and see what you put in your right behind your meeting. Because they're always trying to wiggle out.
Sure. Yeah, good strategy. Yes.
So obviously when you do, the question's really particularly about borderline, but I guess I'm not saying it.
Sure.
So obviously in treatment, there's a goal of getting them sober and giving them tools to stay sober. But what is really the ultimate hope for dealing with the borderline personality characteristics?
Yeah, awesome.
Can that actually be gotten over? Are you trying to eradicate that from their behavioral patterns and thinking? What do you do with that?
Yes. So what's the ultimate hope for someone who has a borderline personality organization in a treatment setting? I'll use a quote by Freud. He said, if you think you can change somebody, you're wrong. All we're trying to do is tend the garden, kind of get rid of the weeds occasionally. And so that's, I think, the hope with someone who's a borderline in a treatment setting, is start chipping away at the defenses. If you can hone in on a primary defense and do work around that, I think that's hugely important work. You have a follow-up?
Yeah, and what about beyond the treatment setting? So you team them up, you do that work, let's say you line up a therapist for them or a psychiatrist for long-term care. Is there a long-term goal of them no longer being borderline someday?
I don't know if I'd classify it as no longer being borderline. I think sure. Yeah, I think for my understanding and the way that my kind of bias is, we're all kind of function according to our own biases and psychodynamic theory. The borderline, complete eradication of the borderline, I don't think would ever happen. I think there would be a loss there. Rilke said he didn't want to do therapy, psychoanalysis, because he said, I'm afraid if you drive out my demons, you'll drive out my angels as well. And so I think that's an important thing to keep in mind, is that we're not trying to just get rid of all pathology, you know? It kind of makes you who you are in a sense, a lot of ways, and it drives a lot of talent and ambition and awesome qualities as well. The long-term plan for borderline, I would say long-term psychoanalytic psychotherapy would be a great option, but the complete eradication of the pathology I don't think is helpful. Yeah. No, just for purposes of time, I think we'll just stick with kind of what we did. That's another 20-minute topic. I'm happy to talk with you after, though. Yeah. Yes.
I agree with a lot of your approaches, but CBT also does some research with outcome studies for borderline.
Yeah.
But you can say at least about personality disorders. People's personalities do change over time, over 5, 10, 15, 20 years. And I think they can't stay the same, period. They do change, people change.
Sure.
So it just depends on what kind of, usually we're tending the garden, we get 4, 5, 10, 11, 20 years in terms of how your personality develops over time.
Sure. Well said. Thank you. Yeah.
But I think if I can keep them engaged, first of all, I take them where they are. And then it's like, and it's difficult to do it in a residential setting, you don't have time. If you keep them engaged, and sometimes it's, and they're coming back, and, they're working through the problem. I want to know where they came from, where it all started, right? So it's going back to the beginning, taking back and walking back through, who's mom, who's dad. With family, engaged, and it's about, kind of doing a genogram, just to see it work in a very simple way, so that the whole family can kind of see that this is generational, right? And at different times in history, from parents to grandparents to great-grandparents, and we don't want to know much more past that. But this has been going on, and it was dictated by the times that people lived in, right? And the struggles and the things that they were going through. So, ultimately, it's not to blame anyone, including the person sitting in front of you. They blame themselves. When you get into, at least connect with some of that. You got to keep them engaged.
Sure.
In other ways that you said.
Yeah. Yeah, well said. Yes, sir.
Most sections of psychiatry, mood disorders, even substance abuse now has medications attached to it. But I don't ever hear of any medications associated with personality disorders.
There is none.
Well, I thought I'd ask you
Yeah.
what your thoughts are.
Yeah, the people around them need medication.
Yeah. Yeah. I mean, obviously mood stabilizers. There's a lot of clients that we see, especially with borderline features, are on some sort of mood stabilizer, and it helps.
They have PTSD, something that
Yeah. 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 I think in no way am I saying psychodynamic theory and psychoanalysis the only way to go, no meds. No, I think that addiction itself, and especially dealing with someone who has these kind of traumatic ways of seeing and being in the world, you need to bring as much you can to the table. I think addiction in general needs new strategies, much new strategies. We need to be more open-minded. Yeah.
You talked a little bit about insurances and knowing that sometimes treatment is enhanced. Is there a concern that sometimes you open up something that you won't be able to?
Yeah, every time. Yeah, every single time. There's an approach in this theory. It's called ISTDP, Intensive Short-Term Dynamic Psychotherapy, and it's how to do this kind of work in a very brief setting. 6 weeks, 8 weeks sometimes is all it takes. So a lot of the clinicians that I have at my center will use this approach because you don't want to open them up, let them bleed, and then send them on their way. You have to be very careful about that. And for any program that wants to do this kind of deeper work, instead of just kind of putting not Band-Aids on it, but instead of going deep, then you have to be ready to make concessions when it comes to scholarship in clients. Because oftentimes they won't be ready to leave your program and they're in the middle of some significant work. So having that kind of opportunity or option to treat them either at low cost or no cost is important. Sorry? ISTDP, Intensive Short-Term Dynamic Psychotherapy. Yeah.
What about, I think, in terms of the role of the facilitator and how you manage, particularly borderline in a group setting?
Yeah. How do you manage the borderline in the group setting? So let's talk about an example. Let's yeah. Yeah.
They just have so many different personalities.
Yeah.
For me, most of the time, it's that transfers happen there in the group, and then eventually just say, listen, we've given you a lot of time here today. You've made a lot of suggestions. You offer their support, and now we're going to move on.
Yeah.
Thank you so much for this.
Yeah, that's nice. I always let the group do the work, in a sense. I think it's more powerful coming from one of them than me, because then they really feel slighted. Remember the burn victim? In a group setting, especially if they feel shut down, it'll be hard to kind of recover from that. So like having the group do the work, right? What do you think about what she or he just said? And then kind of cleaning up like you said at the end. Yeah. Yes?
Narcissistic has been knowledgeable in the childhood, and you mentioned that psychopath has been dealing with painful humiliation. What about borderlines?
In their childhood?
Yes.
Yeah, so we went into some detail about that. So what does the borderline deal with in their childhood? So where the narcissist is kind of what did you say, the word you used?
No, I actually summarizing your cues. You mentioned the narcissist has been overwhelmed.
Okay, yeah, so the overwater, underwater, the psychopath grew up in rage and humiliation. Borderline grew up where the love given to them was given inconsistently. So when we brought this gentleman up and did the push-pull exercise, someone with high volume borderline features was told, stay close to me, when they needed to actually be independent and autonomous. And then when they needed to be held and loved, they were pushed away. So there was an inconsistent style of love. Okay. This isn't about Trump, right?
No, it's not.
Okay.
Just piggyback on the thing that she was talking about with, you know how they wear the badge of honor, the label of
Yeah.
borderline? I was wondering if it would be helpful to steer away from the label. Is that something that would be effective, like just not worry about the label that you are borderline and just kind of not focus on that as a
For me, I would go with what they bring. You know, if she wants to wear that badge, let's explore what it means. You know, instead of me convincing him or her otherwise, this approach would say, let's really take the badge and get under it. Yeah.
I just want to tag on a similar thought to what was just raised, and that is, I think we have to be careful about saying this borderline. Rather, I think it'd be better to say this individual who has borderline characteristics. It's like saying this diabetic or this MI patient or this MI. In other words, you objectify, and I think there's a real danger, especially working with people with personality disorders. In step 2, they'll talk behind closed doors, say that goddamn borderline.
Yeah.
And that has to be stopped.
Yeah. Good
At
point.
the leadership level.
Good point. Very good point.
I think that kind of language often leads to people, like you spoke about earlier, sort of wearing that as a badge, that because it's a way to excuse or define themselves, and it's the way other people are defining them.
Sure.
So it becomes sort of the focus for identity rather than looking at other people about it.
Yes. Good. I like that. Yeah. Yes, ma'am.
One is a question, the other one is a comment. The question is, do you find that the disorders are more likely to originate in particular developmental periods, like you talked about, a 2-year-old? In other words, is the disruption likely to have its base in a particular developmental task the child is accomplishing, like at 2 when you push and pull?
Yeah. So all the defenses we talked about, the primitive, before 4 years old.
Right, no, but I wondered if some of them were in the bonding, in the first year, and others were in the separation in the second year, and truthfulness in the psychopath at 4 or 5.
Sure. There's a lot of research being done right now, and even the last kind of 10 years. It even studies kind of in utero. So you can really go back as far as you want. I think the primary point being is it all happens very early, and it kind of sets the stage for what happens later.
And the other one is that we did a longitudinal study with borderlines, all three, but the borderlines especially interesting, about whether or not it goes away. So we did a 5-year study starting with adolescents in treatment and found that 5 years later, they still had the same basic personality organization. The ones that were responsive to treatment, their incidence of acting out around it were much, much lower, and their awareness of their own imbalances was much higher, and they fell back into the same patterns under stress. So that the few we were able to follow for 10 years, you know, talked about sort of when their husbands left them or when they dropped out of school, that those were times of stress and they responded in the old way.
Sure.
But they were aware.
Wow, very interesting. Yeah, good work. Are you doing more studies now?
Yes.
Awesome.
So
Yes.
are you suggesting that traumas could have impacted the personality in utero as well, or studies, are they doing studies?
There's studies. Yeah, there are studies. I don't know the researchers' names right now, but
I mean, I know that there's been
yeah. Last question? Okay. Thank you very much.